Good morning, everyone. My name is Shannon Tyne, and I'm a professor of pediatrics at UCLA, and I have the pleasure of working with many of you on activities related to adverse childhood experiences and trauma-informed care. And I'm thrilled to be here today to introduce our speakers, two of whom I know very well from my prior work and my current work, and they will be presenting Navigating an Unprecedented Reform Landscape, Equity, Justice, and the Youth Mental Health Crisis. Our first speaker is Alex Briscoe. Alex was appointed director of the Alameda County Healthcare Services Agency in 2009, where he led one of the state's largest public health systems, overseeing health and hospital systems, public health, behavioral health, and environmental health departments, with an annual budget of $700 million and more than 6,200 full-time employees. Before joining the county, he was the director of the Chapel Hayes Health Center at McClemens High School in West Oakland, a satellite outpatient center of the Children's Hospital and Research Center in Oakland. Mr. Briscoe's work has helped design the nexus of public health and public education. He has designed and administered a number of mental health and physical health program services in the child health system, including home visiting programs, programs for medically fragile children, and clinical and developmental programs in child welfare, juvenile justice, and early childhood settings. He has also served on the Alameda County First Five Commission, the Kaiser Commission on Medicaid and the Uninsured, as well as a number of public health and private boards and commissions. Mr. Briscoe is a mental health practitioner specializing in adolescent services and youth development. He has advised or collaborated with a number of local and national foundations, including the Atlantic Philanthropies, the RWJ Foundation, the Annie E. Casey Foundation, the California Endowment, and most recently with Tipping Point Community. He has specialized in Medicaid policy and administration, emergency medical services, youth voice and crisis counseling, and safety net design and administration. And I'm proud to say that I have been collaborating with him for years on many initiatives related to children's health, both during my time in San Francisco and now in Los Angeles. He is a true partner. Our second speaker will be Rhea Boyd, who is a physician and MPH. She's a pediatrician and child and community health advocate. She works clinically at the Palo Alto Medical Foundation and serves as the chief medical officer for San Diego 211. She teaches students and trainees about the relationship between structural inequality, poverty, racism, and health, and is active in the American Academy of Pediatrics, serving on the board of California Chapter 1 and as a member of the AAP's National Executive Committee on Communication and Media. Over the past 5 years, Dr. Boyd helped organize a group of public health officials, clinicians, community advocates, and funders to evaluate and address the impact of harmful police practices and policies on child and public health. She also worked with a San Francisco-based tech nonprofit to increase access to social services across the Bay Area as a means of improving child and community health. Dr. Boyd is the author of a blog, Rhea MD, and where she currently engages in the intersection of health and justice. She earned her MD at Vanderbilt University School of Medicine and completed her pediatric residency at the University of California, San Francisco, where she participated in the Pediatric Leadership for the Underserved program, and where I had the honor of serving as her continuity clinic preceptor. I was there when, and in 2017, Dr. Boyd graduated from the Commonwealth Fund Mongan Minority Health Policy Fellowship at Harvard University School of Public Health, where she received an MPH. It is a true honor to have both of you speakers here today. We look forward to their presentation.
Hey y'all, Shannon, thank you so much for that beautiful introduction. I'm just going to screen share really quick so we can jump in. We have a packed presentation for you guys today, and I'm really excited about it actually, because we're going to do grand rounds a little bit differently than I've ever done it before. Let's jump in. So today we're going to be talking about what we've all been experiencing through our clinical work, what many of us are witnessing in our own families. But there's something happening to our kids. If we think about it as a crisis, as many people have framed it, that alarm has been sounding. In 2018, there was a study that found that Black children aged 5 to 12 were about twice as likely to die by suicide as white children of the same age. In 2020, in the midst of the pandemic, we saw that emergency department visits and mental health emergencies in particular rose for both kids aged 5 to 11 and kids aged 12 to 17, But if you disaggregate the data by gender, we saw that emergency department visits and suspected suicide attempts increased nearly 51%, specifically for girls aged 12 to 17. If we looked in the year 2021 and compared those rates to the same period in 2019. In 2021, there was also a study that looked back from 2003 to 2017 and found that suicides increased for Black children, particularly age 5 to 17, with the largest increase among teens age 15 to 17. That data, when disaggregated by race and gender, found that 2.5 times as many Black boys died by suicide as Black girls, but the annual increase among Black girls, which was 6.6%, was more than twice that of Black boys. Then just 3 months ago, the CDC's Morbidity and Mortality Weekly Report revealed that from 2018 to 2021, suicide rates increased 36.6% for Black kids and youth and transitional age youth aged 10 to 24. If you pull out part of that larger table, which I did here, so this is a table from the CDC's report that's looking at the annual number of suicide rates and the rates of suicides per 100,000 in the population. And we think not just about the largest increase over time from 2018 to 2021, but who actually has the largest absolute suicide rate? It's actually Indigenous folks, American Indian and Alaska Native population. And I just put a box around it here. If you look in 2018, for kids and young people aged 10 to 24, the baseline suicide rate was already 31.1%, which you can see from the data from Black Youth Above. In 2018, the baseline suicide rate was 8.2. So that's more than 3 times the rate of what Black children are experiencing. So while the rate of increase of suicides among Black children is incredibly alarming, the alarm is also sounding for Indigenous kids, and it's been sounding for quite a while. And so if we re-ask that question about what's happening to our kids, but we pay specific attention to what's happening to our Black, Hispanic, and Indigenous children in particular, we need specific language to talk about what's happening. Usually, and for many of you as trainees, you consider each patient or client that you serve individually, and you think about what's happening to them as a pathology, perhaps, that's happening to them in their own context, in their own household, in their own school. But if we think about what's happening to all of our kids at a population level here in California and across the country, we need a different frame to talk about what's happening to our kids of color. I'm going to give you one tool or one way we can start to think about that. We're going to talk just briefly about adultification. So if we're going to move from thinking about kids individually and in a clinical frame, and instead think about kids at a population level and what's happening to them socio-politically, we have to confront the ways that racism shapes kids' social and political positioning in our country and how that then comes to harm their health. Adultification is one of those ways. So we have to confront the fact that we live in a country that adultifies or criminalizes kids simply for not being white. What do I mean by that? So adultification is a process by which certain kids are perceived as older than their actual age and thus regarded as less innocent, which makes them subject to more callous and sometimes even violent treatment by the adults around them. That misperception of Black children happens incredibly young. It happens as early as age 5 for Black girls and age 10 for Black boys, and it is not benign. When we misperceive kids and we deny them the presumption of innocence, we as a society, as the adults who are meant to care for them, it changes how we protect them legally and socially. What happens is when kids of color are routinely misperceived as older, the protections that are typically afforded all kids as a function of their younger age and their immature developmental stage can come to uniquely benefit white children as a tangible material advantage of their whiteness. That process has 2 related effects. First, it absolves us from looking at white children with any scrutiny around their behaviors. And secondarily, it contributes to the inordinate policing of children of color and their behaviors. So children of color come to be routinely policed, formally and informally, in nearly every setting in which they are just trying to exist, including in utero. Those exposures negatively impact their mental health and their physical and social, emotional well-being. So when we talk about what's happening to our kids, it's critically that we understand the structure and socio-political drivers of mental illness. And that's what we're going to do today, which I know may be a bit of a departure from how we usually talk about it. And so to do that, we have to start naming the many ways that racism harms kids. And we have to start talking about solutions that actually help us start to address racism and discrimination as health and the health consequences they cause as the public health crisis that they are. So if we're going to do that, the question is, who should we turn to do that? And that's why I was really excited to have a little bit of a different ground rounds than we usually have. Usually I sit up here and I talk about what I think about racism and how it's affecting our kids' health. And then towards the end of the presentation at somewhere, I'll say, and we need to turn to those who are most affected by the system, right? But today we're actually going to do that because it's that critical when we're thinking about how we're going to address this crisis. So the next person who's going to speak is Nancy Netherland. I am thrilled to have had the opportunity to work with her at the California Children's Trust, which is a statewide initiative that has been working on some pretty major behavioral health reforms around Medicaid in the state. And so I'm thrilled that Nancy's going to speak to us. She is a parent, a caregiver, and an advocate. She is also the director of parent and caregiver engagement at the California Children's Trust. She's mother to 2 daughters, both of whom are former foster care children who live with rare and chronic complex medical needs. She founded Kids and Caregivers, a nonprofit supporting families, caregivers, and providers of chronically ill children through wellness, navigation resources, coaching, and peer-based activities. I'm thrilled for us to hear a bit from Nancy about her experience in the system. And then after Nancy, we're going to turn it to Alex, as Shannon shared, because I want us to talk a lot about how Medicaid works. When we talk about the structures that can lead to health impairments, we don't always learn about how we can actually reimagine those structures. And so we're going to spend a lot of time talking about the nuts and bolts about how Medicaid works and some of the incredible work Alex has been doing with the California Children's Trust to do more about how racism harms kids' health. So I'm going to stop share. Oops, can I button my little? Here we go. Thanks, Nancy.
Thank you so much, Rhea. I'm going to jump right into screen share. It's a pleasure to be here today. And let me just grab these up. Okay, this is my biggest, great, perfect. Hi, my name is Nancy Netherland, and I'm so grateful to be here today. I'm going to talk about the context of care as from the perspective as a caregiver. I was lucky enough to do graduate studies in psychology and actually get my training at UCSF. I went on to work at California Pacific Medical Center and worked in some integrative care programs. What I didn't prepare and what I wasn't aware of is how hard it was going to be when I adopted children and initially fostered them, to really provide them with care in a timely manner. So I was a little bit naive as to what it was going to be like to have kids who were insured by Medicaid. One of the things that I was not ready for was waiting for pathology. I was not aware at that time of what really is a systemic split between the mind and the body. So when my children who were adopted through foster care, they had all kinds of early exposures, got diagnosed with some chronic illnesses that also were quite painful, I knew that they were increased risk for downstream behavioral health and substance use disorders. So I knew that. So I went to their pediatrician and I said, hey, I know that we've got these extra risk factors. They have risk factors from prenatal through early childhood exposures. And now with these illnesses, they're at even more risk for having behavioral health problems. What's there, what's available? And she said, you know what? There is nothing available right now that's covered by Medi-Cal. We basically have to wait for a diagnosis and before their service is triggered. Now, things have changed in California, but that's how it was not so long ago. And I was really surprised because I knew that there was a commitment to prevention and coordination of care, especially in the body. So if my kids had been pre-diabetic, we wouldn't have waited for diabetes or a higher A1C. And we certainly weren't waiting for, respiratory distress or unremitting asthma in my daughter who had respiratory problems. I want to share what it's like now. So my oldest, Sarah, 16, and did eventually get a diagnosis. And I want to talk a little bit about that process. As a young person living in a Black body, there were many points in our journey where people would look at Sarah's behavior as volitional, and they would look at it as non-compliant or defiant. And what I would invite her practitioners and her providers to consider was that maybe that there was some structural racism at play, and that this was a kid who was struggling with a lot of trauma. We ultimately ended up losing her dad to an unexpected illness, and Sarah has learning disabilities as well. And so I felt like there was a constant reminder in the exam room and in assessments that there were some inherent biases that might be affecting the consideration of her diagnoses. So it took a long time, but eventually she was diagnosed with anxiety and depression. And the colored balls below just represent the different places that we've sought care for Sarah, who's still insured by Medi-Cal. So primary care all the way through community-based organizations. I also want to say that while the system identifies Sarah as a former foster youth with learning disabilities, ADHD, anxiety, sensory processing disorders, and living with a rare neurological pain syndrome, what I think is most important is that Sarah identifies as African American, and as of about a week ago, F to M trans, and a lover of dogs, nature, and graphic novels. And despite living in a Black body and being 16, we're still switching pronouns, is in fact a young person who's tender. So I was interested in what some of the bigger data meant in terms of accessing care. I was able to find this recent physician report. Patients accessing mental health services on time is 13% for providers who've got general panels. When you look at pediatricians with panels of 50% of Medi-Cal patients or more, only 8.1% of their patients are getting care on time. A recent Senate Finance Committee discovered that among individuals who need behavioral health care, the median time from symptom onset to first treatment is 11 years. Timely access is being measured these days in California. And recently it was found that for general commercial plans, 59% on average of plans assessed were meeting timely state standards. It was lower for Medi-Cal, as low as 45% for some of the largest Medi-Cal managed care plans. I also just want to make a note that when we talk about timely access, it can mean very challenging travel times. You'll see up to 90 minutes depending on where you live in some parts of California. That is even if there are providers available. So the CDC recently released data showing that there were 8 counties in California that have no psychiatrists who treat children, and 5 counties have no psychologists. So it's probably not entirely surprising that even prior to the pandemic, that there were up to 63.6% of kids who did not receive care for depression. I want to also just share again our personal experience. I'm a skilled advocate. I grew up working in healthcare, I like to say, and even before I had kids, was really familiar with systems of care. I work in FQHC land, my day job. Even with all that background, have hit a lot of walls in trying to get care for my child. I was surprised. I was in Sacramento recently testifying in front of the state Senate's Health Committee, and one of the most venerable activists that I know, amazing policy person, was sharing her experience and challenges in getting her child timely access. And I was really surprised. So it's pervasive, and we're people who have a lot of privilege. I never forget the privilege that I have, and yet it's been very difficult for me to get timely care. So I want to focus on what I think is available, and what's offering me hope as a family member. I'm really thrilled with the removal of, with the removal of diagnosis. It's going to be a thing of the past to hear from a pediatrician that there's no services available for kids like mine. With no diagnosis necessary, that means children can get care earlier and further downstream. upstream, I mean. There's the new dyadic benefit. Children don't go to the doctors by themselves. Their caregivers will be involved with their care now. I'm also a huge fan, and my other daughters benefited from e-consults, where psychiatrists are pushed into primary care settings via things like the CAP program. I also find great hope in centering schools. I don't know if you noticed in one of my other slides, my daughter was able to get care very quickly through her school. And then finally, I'm really looking forward to the expansion of the workforce and the recognition and reimbursement of trusted messengers, peer-based workers, and community health workers who will support the existing and licensed workforce. So those, I think, are things that I hope to make this a historic slideshow in the future. And then finally, I want to say that the future of mental health is now, and we all have an opportunity to make sure that our kids get the most care possible. I want to thank you so much.
Wow. Hi, everybody. I'm just having one of those filled with emotion moments of the people you get to work with. So thank you, Nancy and Rhea. My name is Alex Briscoe. I'm the principal of the California Children's Trust. And I'm going to move quickly through some epidemiology, but mostly why I'm doing so is so that you can have these slides. Some of us don't even believe in intellectual property in the pursuit of social justice. So this deck will be available. We love it when people take our stuff and reproduce it. The Children's Trust is a 5-year initiative. We have a year and a half left. We're going to sprint to the finish line. And I'm going to try to take you through a lot. So heads up, but I'm going to try to distill for you the architecture of Medicaid in California, as well as the unprecedented reform landscape we're in, including about $10 billion of investment that's flowing to youth mental health. So stick with me. Again, I'll move quick. These slides will be available, and hopefully we'll save some time for some questions. To emphasize Rhea's points, it's us, it's not young people. So much of what Rhea was saying distills to this fundamental question of what will we do as a culture when we wake up and realize that twice as many of our children are killing themselves or trying to kill themselves. And even when you look at this from a cost perspective, our health system perspective, mental health and substance abuse are the leading cost drivers in our America's healthcare system. This is a very rough metric. It's basically butts and beds and days on disability. This is called daily adjusted life years. And if you want to know, it actually is us, because it's not any other Western developed nation that has a problem anything resembling ours. Among comparable countries, we have the highest rate of death from mental health and substance abuse disorders, like by far. So the social construction of our challenges is readily apparent, and it's tied, of course, to 400 years of structural inequality, but also tied to something that's been happening, frankly, since the turn of the millennium. This crisis we've been naming, we need to be really careful not to frame it in the context of COVID, because this data I'm about to show you happened in the decade before COVID. We saw a 104% increase in inpatient admissions for self-injury, a 50% increase in pediatric bed days. Young people actually were telling us we were not listening. This is data from the California Healthy Kids Survey. And then I think the clinical frame for this is we suck. We rank 44th in the nation in screening, 48th in access to care for kids in mental health. The kind of progressive politics of California crashes on the rocks of what actually happens for poor kids. And this is the data that Rhea showed. The left-hand side, Rhea already spoke to, but on the right-hand side, I just wanted to kind of wrap it up. When you add what was happening before the pandemic to whatever you call pouring gasoline on a fire, you get these striking increases in utilization in the level 1 pediatric trauma centers across California. This happens to be Rady's, a 1,700% increase for those of you who trained in or are working in emergency room settings. These are small 4 to 6 room kind of settings. This type of increase is just impossible to hold. So we have to change how we do stuff. And one of the greatest challenges for all of us is to accept that maybe more of us isn't the answer. And an invitation I'm going to offer to all of us who work in healthcare systems is that the medical model is broken and is complicit with systems of oppression that are actually driving the challenges we face. 75% of mental illness manifest during the time that young people use the doctor the least. Provider shortages and mental health practitioners create an added challenge, and diagnosis-driven models are only appropriate for some children. Working in the Oakland schools at a level 1 pediatric trauma center and in child welfare and juvenile justice, I have literally billed hundreds of millions of dollars of mental health services to Medicaid. I would say about 20% of the kids I served met diagnostic criteria. The vast majority of young people and families that I have worked with over 25 years were not pathological. They were dealing with living in a culture that told them they weren't worth anything or having really bad things happen in their lives. So the pathologizing of their experience to justify reimbursement for a largely white professional class has to be named. And how did we get here? We don't even have a common framework. Behavioral health is actually the models we're using. If you throw out Freud and Skinner, are 20, 25 years old. Our public systems are deeply fragmented, though that's not the only problem. And we are still struggle with this basic perception of what is mental health. Is it an essential benefit in a managed care plan? Or is it a public utility? Is it a public health benefit? We're just not clean. And something you're hearing, a theme here, is our definition of medical necessity, meaning the bar to entry is outdated. It's inconsistent with what we know about adverse child experiences and the impact of trauma on healthy development. So we simply must change and remove this critical barrier to care, which is the pathologizing of young people. And we have some good news on that. So to switch to a more hopeful frame, this is our moment. For those of us who care about behavioral health, like if we can't get stuff done now, we have to quit and go sell widgets, because there's never been an environment like this. When Rhea worked with us to start the trust in 2017 and 2018, we literally were screaming into the wind. The director of healthcare services at the state told us that California's behavioral health system was functioning fine. Like we could not get a hearing for what we knew to be a socially constructed epidemic based on structural factors. So we are now seeing state and federal leadership. Californians are saying that the health and welfare of their children is of the utmost importance to them. And we're finally talking and formally incorporating things like adversity and racism into our definition of eligibility and criteria. And I dropped in the chat a brief summary of the new family therapy benefit, which makes California the first and only Medicaid program in the nation to qualify beneficiaries for access to care based on an experience of discrimination, food insecurity, housing insecurity, and the other adverse child experiences. And we got some money. $10 billion is about to flow, and I'm going to take you through it. And it's going to be inadequate, and big chunks of it are going to be siphoned off by entrenched interests. But it's certainly better to be trying to engineer reform in the context of $10 billion than it is to be doing it in the context of cuts. But to take advantage of this sort of unique opportunity, we have to focus on where the money is flowing. And increasingly, the money is flowing through the managed care plans. So in Los Angeles, you live in what is now a 3-plan county. LA Care is the public plan with about 80% of beneficiaries. Molina and HealthNet, they also sub to other plans. So to be clear, it's more complicated than this. But the plans have become increasingly central to the reform landscape of Medi-Cal, meaning DMH is less important, LA Care is more important. We have to actually reform how we pay and do so that we move away from clinic-based services and supports to extender type models, team-based care, very similar to what we did in pediatric primary care in the 80s and 90s. Dr. Thomas Bodenheimer at UCSF. I know Shannon is well familiar with his work. When we decided that every child needed a primary care home, we knew there weren't enough PCPs. What did we do? We expanded scope, NPs, PAs, LVNs, MAs, but we also shifted who did what. And the concept of working at the top of your license changed. And so to distill this idea, what we really mean is the days of therapists working solo in 50-minute sessions need to stop. That's not what young people want, and it's not an effective use of scarce clinical resources. We should be seeing therapists working with teams of wellness coaches, of doulas, of peers, of community health workers who should be managing a population of young people. We don't give everybody a CAT scan. Why do we give everybody a 50-minute session? And we must simply expand the nature and scope of who does the work. This is called the expanded provider classes. And I'll tell you about the 4 who've recently been approved in Medicaid. And finally, if I spontaneously combust and you take nothing else from what I say, I hope you will join me in reimagining mental health as a support for healthy development in a toxic culture, not a response to pathology. So let's teach you Medicaid really quick. California's version of Medicaid is called Medi-Cal. It covers about a third of all Californians. It's about 105 billion. 12 billion is on behavioral health. And if you think, wait a second, I thought behavioral health was the leading cost driver, you're correct. We spend too little. and it covers about a third of all Californians. But this misses the point for kids, because kids are actually 50% of all births are covered by Medicaid. And when you shift to who covers kids, you'll see that actually Medi-Cal covers more than half of all children in the state. And you may ask how that is, and for the policy wonks in the room, in 2015, we rolled our S-CHIP program into Medi-Cal. So historically, Medi-Cal covers kids 0 to 138% of federal poverty, and S-CHIP, or what used to be called Healthy Families, covers you 138 to 266. In 2015, we did two important things. We made them one program, 0 to 266, and we covered undocumented children. So now all children in California, 0 to 266% of federal poverty, are covered by Medi-Cal. And they get services primarily through two different payment systems: specialty mental health, the county mental health plans, and managed care plans, or non-specialty mental health. And as you'll see, this number will be updated shortly. They're serving about the same number of kids, but the managed care plans didn't even have a mental health benefit until 2015. A little bit more bad news. We rank in the bottom third nationally in spending. Kids are 42% of all enrollees and only 14% of all expenditures, 44th, now 48th in the nation in access to care. And this is just one example of numerous audits about how poorly managed care plans do in meeting the needs of children. And remember, the financial construct of managed care is to focus on the high-cost consumers. So those of you like me who spend a lot of time in utilization management and utilization review meetings know that the vast majority of those are focused on high-cost adults, very few on young people. So as I mentioned, there's been a significant increase in Medi-Cal since 2015. As I mentioned, everyone under 21. And actually, we're bringing in the 25 to 50s into Medicaid undocumented in July. That's super important. And unfortunately, only 6% of children get anything at all, and only 3% are on ongoing care as measured by 5 or more visits in a year. So our underperformance in the context of the crisis is striking. As Rhea said, if you don't disaggregate this data by race and class, so acknowledging how racism and poverty, and actually specifically designing reimbursement to address it by shifting agency, who does the work, and power, who gets paid to do it, is the strategy we are proposing. And we're making some progress. So Medi-Cal itself actually functions in a very simple way. Every Medi-Cal expenditure, every Medicaid expenditure has two parts, and two parts only: a state share and a non-federal and a federal share. So, right, it's pretty simple. This state share is called a certified public expenditure. The federal share is called federal financial participation. So one way to think of Medicaid is like a pot of gold in DC. You put up $1 to get $1, and you follow the rules. Pretty simple, right? There's formal definitions for these two components, but this is literally a pretty simple architecture. And let's talk about how we screwed it up so bad. That federal dollar flows through the state. How does it show up in the lives of children and families? The first and biggest way is it throws through the managed care plans. In Los Angeles, again, that's LA Care, HealthNet, and Molina, and then subbed out to Promise and Anthem. Your county mental health department, up until 2015, the only place to get mental health services for kids on Medicaid was through the county mental health department. It's called a carve-out. Now, both of these systems offer behavioral health reimbursement. The managed care plans are called non-specialty mental health. The mental health plans, or the county departments, are called specialty mental health. School districts can directly bill Medi-Cal. Community health centers, as you know, get an enhancement. Public health departments can bill for case management and administrative activities. Public hospitals bill directly, and the regional center is itself a 1915I and 1915H waiver program. This is the architecture of our failure. For any of us who've worked in these bubbles, you know you spend a lot of time pointing at the other bubble saying it's their kid. No, it's their kid. And one of the essential reforms that is coming right now through something called CalAIM is the envisioning of the managed care plans as the healer of this fragmented safety net. And as difficult a proposition as that is, I can see why the state is pursuing it. Almost all child-serving systems function the same way. There's a federal action tied to a state action, but it's administered at the county and local level. This is true of the foster care system, child welfare. It's true of your juvenile justice system. It's true of your early childhood system. It's true of education, and it's true of the regional center. But from a hopefulness perspective, we can fundamentally shift these systems and their carceral proximity by developing a healing-centered approach And Medi-Cal and behavioral health is literally the common denominator of our fragmented child-serving safety net. So do we have the skill and will to build team-based care models of care that integrate payers across fragmented safety net systems? And the beginning of that is happening, and let me try to take you through how it is. So this landscape I mentioned, it's about 10 billion, and I'm going to highlight sort of one way to organize it. There are three big buckets of funding coming. The first is the California Children, Youth, and Behavioral Health Initiative, a $4.4 billion initiative. When I'm finished presenting, I'll drop a link in the chat to a summary of all of its elements. It has a bunch of stuff in it, but the way to distill it is schools, pediatric primary care, and workforce. So there's a bunch of grant programs, there's a bunch of stuff it does, but what it primarily does is create new workforce classifications, creates ongoing and grant-funded programs for schools, and creates the new dyadic benefit. The new dyadic benefit, basically the way to think of that is Healthy Steps or PCIT. It creates a reimbursement strategy for integrated behavioral health for caregivers when they bring their kids to the well child visit. CalAIM is the second bucket or way to think about things, and it has new benefits like enhanced case management, like community supports, like the new community health worker benefit. So one important way to distinguish these is the CYBHI and CalAIM have some overlap, but their funding buckets are largely distinct. And then finally, the state has made some big investments directly in schools through the Community Schools Partnership Program, through mindfulness in schools and other places. So if you're trying to make sense of this really kind of crowded reform landscape, one way to organize it is to look at the dollars in the Youth Behavioral Health Initiative, look at CalAIM, and then look at the direct investments from the state. These are the 10 elements of the California Youth Behavioral Health Initiative. As I mentioned, there's lots of components to it, but I want to highlight one that isn't talked about very often. It's called the Universal Fee Schedule, number 10 here. Beginning in 2025, schools become automatically in network for all payers, commercial and Medi-Cal. And I know for probably residents, this is a hard thing to hold, but one way to think of it is if you got in your car today and drove to Glacier National Park, and heaven forbid you got in a car accident, and you got treatment in that emergency department, that emergency department is not in network for your health plan, but your health plan must pay because all emergent services delivered out of network must be reimbursed at 100% of charges. Basically, what this California Youth Behavioral Health Initiative does is create schools as automatically in network for all managed care plans. We are the first and only state to have done this. It's a transformative piece of legislation. There will be litigation, but one way I think for docs like you who are training to think about is schools will be as important to payment networks as doctors' offices, ambulances, and clinics are. Sorry, duplicated that slide. And to highlight a couple of the elements of this reform landscape that that Nancy mentioned, and I want you guys to hold, is we have done this really transformative thing, which is we've added 4 new provider types to Medicaid in the last year and a half. We've added community health workers, CHWs, doulas, which get paid $1,200 a birth, which is really, really important. Like that's a good rate. Certified peer specialists and behavioral health coaches, or what are now called wellness coaches. And when you're looking at a new provider type, we have some guidelines that I'll drop in the chat as well to think about it. Is like the way to think about how useful this provider type will be is what can they do, their scope of practice, who credentials them, who says they are who they say they are, how do they sign up to get paid, and with whom, which of those bubbles is going to pay them, and then the payer, and then finally rates. What are they going to get paid? And for instance, the doulas are getting a very good rate, $1,200 per birth. The CHWs are getting a very poor rate, $26 for a 30-minute session. So I think the rates are ultimately the most important thing to determine the viability of these new classes. But to put those classes onto, sort of put them all together and help you hold and understand it, there's a bunch of investments happening right now for peer-to-peer programs in high schools. So I won't go through all of them, but there's a bunch of them. And these new programs are now being tied to the SB 803 peer specialists, the new community health workers, the doulas, the wellness coaches. You could already bill for rehab specialists. We are now allowing for billing for interns and associates, and then finally a licensed therapist. But we have just reimagined over the last year and a half a pipeline, a career pipeline, where you could literally begin in high school, getting paid as a peer mental health specialist in a high school, and then begin a career pathway all the way to licensed therapist with 4 or 5 new types of providers who are reimbursable in Medicaid. It goes without, I hope it goes without saying, but I'll say it. 81% of children in Medicaid are children of color, and 80% of licensed behavioral health staff are white. Representation isn't everything, but it is a lot. Young people need to see folks who look like them, and we must simply build a health career pipeline for impacted communities to use their wisdom and intelligence to serve people who look like them. We reform medical necessity, Nancy mentioned this, by removing diagnosis as a prerequisite for care across both delivery systems. The first is through the new family therapy benefit that I dropped in the chat. And then the second is through the new dyadic benefit. I'll also drop that in the chat. These are fundamental shifts to who is eligible and how we qualify young people. And what I would say is when we did this, we thought it was an important symbol of reform, but it turns out to be far more than that. I'm not sure anybody's billed more adjustment disorder not otherwise specified than me, but we need to teach clinicians that they don't have to lie, they don't have to game the system, and that the people that they're serving are not pathological. They're dealing with a toxic culture. So as a last slide here, what I would say to folks trying to track the landscape is things are changing. There are huge changes happening in Medi-Cal. In order to navigate them, you have to know that Medi-Cal is not one thing. It has many faces, the bubbles I showed you. And looking at how to tap multiple ones of them is an unfortunate, but necessary reality for safety net systems. But one way to hold this is the increasing centricity of the plans. Medi-Cal Managed Care, again, HealthNet, Molina, and LA Care, have new benefits, community supports, enhanced case management, family therapy, dyadic benefits, the CHW benefit, and new money, including cited and IPP, that they can invest to build networks of care to focus on the social determinants of health. So maybe set aside some of your preconceptions and reimagine the opportunities to work together with the managed care plans. Track the new benefit and new and emerging benefit design and construction, and mine the new provider type opportunities to build a healthcare system for people, by people. I know I went fast, but I'm going to stop so we have some time for some questions. Thank you so much for listening.
Thank you so much, Rhea, Nancy, and Alex, for a great presentation. I work in the primary care space, and as you know, and also really extensively with mental health through the foster care system that is integrated into the county. And this is so complicated and so important for us, particularly the audience of mental health professionals, to really begin to engage in. And we're so lucky that we have people like you doing this work. We have a few questions that I'll go through in the chat. If anyone else would like to put any more, we'll do as many as we can. The first question is related specifically to UCLA. Faculty have advocated to see Medicaid patients in outpatient psychiatry, but there's been a lot of pushback at the institutional level because of poor reimbursement. In light of all these new funding streams, what would you recommend as an approach for helping to address this disparity at UCLA?
Well, geez, I don't work for UCLA, so I get to go at it, right? Any institution that chooses not to serve Medicaid is cutting itself off from the primary payer in the reimbursement landscape. Medicaid and Medicare are 60% of all reimbursement, and Medicaid itself is 55% of all kids. And if there is one place in the entire healthcare system where Medicaid pays competitively, if not better, than the commercial plans, it's behavioral health. So I'm sorry, I think I heard that question right, which is how do I get my institution to pay more on Medicaid? And I would say try to schedule a meeting with me and them so I can show them the money.
Great, thank you. The next question has several questions, and I'll just read them all, and if you need me to reiterate them, I will. Have you all looked at the French system that has kids in school for much longer days and also has shop like carpentry and cooking or internships to help with graduation? And then they can do these internships rather than being in academic classes that don't work for everybody, and have a sense of self-worth via this kind of work. So that's the first part. The second one is, have you looked at poverty in sports and seen any correlation between mental health balance versus problems? Is the death increase related to fentanyl ingestion given this recency? And finally, is the 6% of disabilities for kids, physical, mental, et cetera, stable across the centuries and decades? So I'll go back and say French system. Do any of you want to comment on that first?
So I haven't looked at the French system specifically, so full stop. What I can say is part of the package of reforms in that very busy slide was the $3 billion expansion of something called ELOP, the Expanded Learning Opportunities Program. So schools are deeply troubled in California, but they still represent our biggest and best hope for reforming the way we support the social and emotional health of children. The danger is replicating the medical model in them. And so I think your question is super well taken. From our perspective at CCT, we need Medi-Cal to reimburse things that aren't traditional medical model supports. And that's one of the deepest and most challenging tensions we're facing in the reform landscape is clinicians know how to be clinicians and health plans know how to pay claims. So teaching clinicians to behave differently. I really love Nancy's quote about her son. Like the way that health systems identify and define children isn't the way that children think about themselves. So what we say is the future of mental health looks more like a support group, more like mutual aid, more like cascading mentorship than it does a psychotherapy session. So sorry, I'm not familiar with the French model, but we are definitely believe in the idea that schools should become centers for social and emotional support and focus on non-clinical interventions.
Great. Just to refresh your memory, the second one was about poverty in sports and whether the death increase might be due to the fentanyl and other overdose.
I will defer, other than the Title IX studies, which I'm sure folks are familiar with here. I am not aware of specific studies, though I would project that involvement is protective as a protective factor. Certainly fentanyl and it is complicit with the higher death rates, but that's not all that's happening. Like, I think that's too simple a solution. And I think to many of the points that Rhea so expertly made, this is a socially constructed epidemic of despair among children. It is not simply that they're taking pills laced with fentanyl. It is far, far deeper than that. And the origins of it are in a culture that equates fame with merit, wealth with value, and is built on 400 years of structural inequality.
Thank you. And then the last part of that question was when you mentioned the stat of 6% disabilities for kids, has that been stable or is that on increasing? Yeah, that 6% is actually what's called the penetration rate. It's not the percent on disability. 6% is the number of those it's now a little less than 5.7 million of that, about 5.4 million kids on Medi-Cal. 6% of them touched the system in some way over the last year. 3% of them were seen 5 or more times. So this is a terrible term, but we call it the penetration rate for Medicaid. And it's incredibly low. And even if you acknowledge that the medical model is ineffectual and inappropriate, it's insufficient no matter how you measure it. So, somewhere between 14 and 20% of young people meet diagnostic criteria annually, and 6% are getting seen, 3% are actually in care. I think it is fair to say that our behavioral health system provides very little and often provides the wrong thing at the wrong time. I'm married to a pediatrician who trained under Shannon, and I can tell you that I now know how to piss one off, which is you either talk about behavioral health or screening, and you can get an earful. Well, you know how I feel. Screening without something to act on is like having a mammogram and no surgeon to refer to. And I think we all struggle in that area. The next question is about sustainability. What does the sustainability of this funding and care provision look like? And I would just add the preface to it. What does the infrastructure building look like? Because I think a lot of these things look really good and sound really good, but the devil's in the details, and we've all seen already with implementation. So implementation and sustainability, how do you see that with this funding?
So I will answer this one because it's in my wheelhouse, but then I would love to make sure that Rhea, Nancy, so I'm not talking too much here, but that question is, I think, super important. First, to acknowledge it before I answer it, most of these investments were made in a time of $100 billion budget surplus. So, like, I think it's easy to look good when money is falling out of rich people's pockets. And a lot of these dollars were simply thrown at the existing system with very little thought for how that system needed to be reformed. So I think it's fair to say money flooded the system in the last year and a half, and few fundamental systems changes have happened. And the sustainability picture is deeply murky, particularly in schools who got huge federal stimulus dollars, big community schools partnership grant money, big youth behavioral health initiative money, all tied to this potential promise of sustainability through that thing called the universal fee schedule. So beginning with schools, I think the sustainability question is a good one, and it's super unclear, and we don't know, because it depends on what the rates are going to be for the non-clinical providers, and it depends on the ability of schools and health plans to get into contract with each other. Now, for pediatric primary care, I think the picture is much, much better, meaning we have now a benefit as of January 1, where you can provide care to mama when she shows up with her kid, or any caregiver. And remember, low-income people interact with the healthcare system the most frequently in the first 3 years of their child's life. So the new dyadic benefit is both viable from a reimbursement perspective, meaning it pays well. Patients you're trying to serve are already in the room. It's a question of learning the codes, and you don't have to have a diagnosis for any of them. So I think that integrated behavioral health and pediatric primary care, we are in the golden age of that benefit, of that opportunity. Like, literally, we should double the number of caregivers getting a mental health service, and we should triple screening rates for kids in pediatric primary care. And it should be good for providers from a revenue perspective. So early childhood, I think the prognosis is good on sustainability. Schools, super murky.
Got it. Thank you. This question might resonate more with Rhea and Nancy. Are there any policy bills, not that they wouldn't resonate with you, Alex, but are there any policy bills we should be supporting right now that will help further this work?
I'll let Alex also honestly speak to that one. This has been so powerful, Alex.
Geez. Well, what I want to say first is that all bills have to get signed by the governor's office. So I sometimes feel like we live in a monarchy, not a representative democracy. So I think a clear-eyed understanding of the pathway for a bill's approval is super, super important. Some bills we have in front of the legislature are ending California's crazy, weird, bonkers same-day exclusion for FQHCs. So that's one we're continuing to promote. We have a couple bills on reimbursement rates for these new provider types, meaning if it doesn't pay a family sustaining wage, it's not worth pursuing. I'll stop there. There's a couple others, but most of them are ones that have been run before and been vetoed.
Okay. And I think this will probably be the last question, and this may apply to all of you. There were several questions that I'm combining together related to, one, the complexity of mental health conditions that we find in youth right now, and two, the different levels of care of providers who can support them. So the questions relate to, we know there's all those buckets, but do you see differences in the kids that are super, super high need and require intensive multi-pronged care, and then those who need perhaps support for one area that could be met with less intensive engagement? And with those two populations in mind, and of course the continuum, how do you see the workforce development with everybody from health workers and care coordinators, all the way up to psychiatrists who we know are in super short supply. So just some comments on that web.
I'm reminded of working with young people in West Oakland, and love to hear what Nancy has to say on this too. But and how I often thought to myself that the families I was working with needed a good job a lot more than they needed a good therapist. And I think what I would say is that even young people who are in serious emotional distress and maybe suffering from, actual serious mental illness, the answer is almost always in relationship. We heal in relationship. And so my call on all of this stuff is like, even for the most seriously acute children, is to focus on their experience of themselves in community. And that is the pathway to healing. I believe in medications. I believe in residential settings for kids when they need it. So I'm not pretending that serious mental illness doesn't exist. But for those children and all of our children, creating opportunities for young people to be in relationship and experience their power and connection to each other and the world is the essential act of healing. And until we get Medicaid to see that as a reimbursable service, we will not have succeeded.
The last thing I'll add is part of the reason I really wanted Nancy and Alex to talk today is so that the trainees, the students, the people who are just thinking about what your career trajectory might look like consider working on mental health from this aspect too. There are so many different roles, not just the role that sits across from one patient at one time and thinks about their individual needs, that thinks about problems that exist across populations and systems, and then can get to some of those larger structural drivers. I'll also say talking to Alex and Nancy at the Children's Trust was the first place where we could have expansive conversations about, for example, what would reparations through Medicaid look like? Like when you talk about shifting the workforce and paying people with government funded programs into career paths that lift families out of poverty and change their material conditions, that is a powerful social justice intervention. And while we have to get into the weeds with people like Alex, who really know the system really well about how you can do that, my hope in them presenting today is that folks like you who are just training and starting out, that you can see that it's possible, that there are actually structural ways through government programs to actually implement some social justice work.
I see Nancy nodding. Did you want to add anything, or you feel like you can leave it
Yeah,
there?
I will add, because something that I look at, I totally agree. The conversation about reparations is essential. We also know there's so much documentation that when caregivers don't have their needs met, children suffer. And so I'm always going to be a strong advocate to look at how we can expand care for caregivers, because we know that it's a system. Children don't exist by themselves. And the racism that impacts our kids impacts their moms and their dads and their grandmas and their aunties. So one of the things that I really appreciate about the work we're doing at the Trust is to create a more expansive vision of what health is and to really pursue chronic wellness. And I think about that all the time. I'm in pursuit of chronic wellness for my children and my family and the caregivers that I'm incredibly lucky enough to support.
That's so powerful. And I think that's a great final message. Chronic wellness is where we all want to end up. And I really appreciate all three perspectives you all offered today, and I'm sure the audience does as well. I know we're at time, so I want to just direct everybody with questions to the cachildrenstrust.org website. I myself have used a lot of data from their publications or from their website in many of the cases I make for trying to get programs implemented. I know particularly for the mental health community and in Westwood, to think about showing the money, showing the potential. I know that's always a great place to start. And then having the personal stories and the approaches that Rhea and Nancy shared is always additive, because people resonate when they hear stories about real humans. So I really appreciate your time. And I'm going to end us here because we are at the hour, and thank you all for your participation. Take care.